Good evening, everybody, from our weekly University of Miami Cerebrovascular and Skull-Base Symposium for another fantastic session today. This is session number 20 in the series. I'm Vyas-Morcos, professor and co-chair of the department, director of vascular and skull-base surgery. Co-directors of the course, Carolina Benjamin, assistant professor in our department, director of the Keynes dissection lab, and Carolina specializes in brain tumor and skull-base surgery. Michael Ivan, assistant professor also in our department. He's a director of research of the Brain Tumor Initiative, and Mike specializes in brain tumor, skull-base, and epilepsy surgery. As well as our two other co-directors, Bobby Stark and Eric Peterson, co-directors of endovascular neurosurgery. Bobby is director of endovascular research. So it's been a great series of lectures. You know where we're beaming to you from, beautiful Miami, Florida. Our two main hospitals are University of Miami Hospital and Jackson Memorial Hospital. And naturally, we are a tertiary referral center for all kinds of neurosurgical conditions. So for the audience, some housekeeping instructions. I am sure you're going to have questions for our speakers and panelists. So send them at any time into the Q&A box, and we will address them in the discussion time at the end of the lectures and case presentations. We don't offer CMEs. Please share the information about our sessions in your social media. I remind our two speakers today that I'd like them each to speak for about 25 minutes. Any of you in the audience who have suggestions for topics in cerebrovascular and skull base, or even speakers you suggest that we invite, please write to me or my email is down there, or you can connect with me on Twitter. Next Thursday, to give you an idea, we have Bill Caldwell and Carl Heilman who will talk about orbital surgery and sphenoid wing lesions, periorbital surgery, which is often really a neglected field of skull-base surgery, with three fantastic panelists, including my colleague, oculoplastic surgeon, Dr. David C., to give us a different perspective on the topic. Every Wednesday, my partner, Mike Ivan, has been directing a very successful Miami Global Brain Tumor Symposium, been going on since April. And next Wednesday at 5 p.m., same time as the Thursday lectures, we have the honor of getting Stephen Kalkanis, who will talk about innovations in brain tumor surgery in the precision medicine era. So please join us as well. Many thanks to the team that makes it happen every week: Ingrid, Roberto, Christina, and particularly Ignacio, who runs this symposium. If you want to see sessions that have passed and you missed, they're all recorded on our departmental YouTube channel. This is the link to it. You can again connect with any of us through the various emails, Twitter, or departmental Instagram, and so forth. Okay, tonight, great pleasure to welcome the three panelists that we have. Nilesh Vyas, Director of Cerebrovascular Surgery and Director of Innova Medical Group in Fairfax, Virginia, and Associate Chairman of the department. Nilesh specializes in vascular, skull base, and I've had the distinct pleasure of having him as my fellow many years ago, and it's been fantastic to watch his career blossom over the years. So thank you, Nilesh, for joining us. David Hasan, Professor of Neurosurgery, Otolaryngology, and Biomedical Engineering, Section Chief Vascular Neurosurgery at the University of Iowa Medical School in Iowa. I have known David for many years now, have been very impressed also to see the rise of his career, his fantastic contributions, particularly to analysis, detailed analysis of aneurysm formation and risk for rupture. And I'm delighted that David, who of course is duly trained, will share with us a case today and give us his wisdom. And last but not least, Errol Veznedaroglu, but of course, since everybody has a problem with his last name, everybody knows him as Dr. Vez. I've known Errol many years also. He's professor and director at Drexel Neurosciences Institute at Drexel University College of Medicine. He's director of the Global Neurosciences Institute there in Philadelphia. Errol has had a tremendous and continues to have a tremendous career as duly trained neurosurgeon, has trained a large number of particularly endovascular neurosurgeons. I've known also Errol through the SUN, the Society of Universal Neurosurgeon, and he is the current president of that society. And we look forward to the meeting next year, since it was scratched because of COVID this year. So welcome to the three panelists. On to the speakers. Elad Levy, professor of neurosurgery and radiology. He is the L. Nelson Hopkins MD Chair of Neurosurgery at the Jacobs School of Medicine at Biomedical Sciences in sunny Buffalo. Elad did his undergrad at Dartmouth, MD at George Washington, residency at the University of Pittsburgh. You can actually see him at the bottom right. I think he went back as a second Janetta lecturer to UPMC in that bottom right picture, I believe last year. Did his fellowship at the University of Buffalo and has stayed there since. And I guess like me and like the next speaker, you have three examples of people who just stayed with their first job and never moved. He did an MBA, Northeastern University in 2013. He's co-director of the Gates Stroke Center and CV Surgery, director of endovascular at the GVI. Interestingly, in 2011, he started concussion research as an organization for children. Elad doesn't really need any introduction in the vascular, endo or open vascular field. He's prolific, more than 300 publications. He's trained numerous endovascular neurosurgeons who, of course, to whom Buffalo is really can be considered the mecca of endovascular surgery. He is currently the CNS secretary and undoubtedly a very near next CNS president. Of course, Elad, as he will tell you, stands on the shoulder of a very special giant whose picture you can see here, Nick Hopkins, and I'm delighted he's joining us tonight. Rafael Tamargo, Walter E. Dandy Professor of Neurosurgery, Professor of Otolaryngology, Head and Neck Surgery at the Johns Hopkins University School of Medicine in Baltimore. Rafael was born in Havana, Cuba, and had a bit of a troubadour life before settling in the US. You can see, grew up in Panama, Costa Rica, El Salvador, and Puerto Rico, which explains why he is so open-minded, perhaps, about many things, but we'll find out tonight if he's very open-minded about endovascular versus microsurgical treatment of aneurysms. So the US was very lucky to have him. In 1976, he came from Puerto Rico straight after high school, and he wasn't messing around. He went straight to Princeton University, where he graduated magna cum laude. Wasn't messing around either with medical school, Columbia University, residency, Johns Hopkins. He finished in '92, and you can see who he graduated with right there in the picture. He became Walter Dandy Endowed Chair, a professor in 2004, director of the Cerebrovascular Division, vice chairman, co-director of critical care at various times in his career. Has had a prolific basic science and clinical research career. In basic science, particularly, we all know him through his work in inflammation in the setting of subarachnoid hemorrhage. Also a prolific writer, more than 300 publications. You can see a young Rafael Tamargo in 2004 in the right there, with Ben Carson of that famed twin separation surgery. And there we go. And it is wonderful pleasure to have both of the speakers here tonight to tackle aneurysm treatment. And I will stop talking and I'll invite Elad to unmute his microphone and share his slides and start his presentation. Ignacio, my mouse is unable to reach. Yeah, perfect. Thank you.
Thank you, Jacques, for that wonderful introduction. I always enjoy spending time with you, whether it's on the debate stage, trying to defend my position against your masterful skull-based techniques, or even now not in person. So again, thank you for the invitation. A pleasure to be here with my friends on this panel. In the next 20 minutes, we'll talk about some of the latest advances in the treatment of cerebral aneurysms. Actually, earlier today, I had a wonderful opportunity to speak with one of your partners, Eric Peterson, where we went transradial for some flow diversion and shared some of the techniques actually developed in your center. I have no relevant disclosures for this talk. And what we're going to talk about is some of the novel techniques in endovascular and how that's really changed the way we evaluate treatment of aneurysms, both in the ruptured and unruptured setting. So we'll talk about flow diversion and how we use flow diversion, which has been around for a little bit. We'll talk about combination flow diversion techniques and what that means and why we use it. We'll talk about intrasaccular flow diversion or disruption, like the Webb device. The dual microcatheter technique, which has its role in a ruptured setting where you don't want to use stents, which require dual antiplatelet therapy. And then a concept we call temporary occlusion repair technique, which is very similar to temporary clipping in the OR, but this is what we do in the endovascular suite should you incur an intraoperative rupture. So let's jump right into flow diversion. There's several devices that exist, and you can see the chart in the lower right-hand corner. Probably the device that's been around the longest in the United States is the pipeline device. Surpass has been on the market most recently, and the Fred device. In Europe, they use the Silk device, and we've used it a handful of times for humanitarian device exemptions. But in general, these all have a similar effect where they divert flow away from the aneurysm. The wonderful part about it is it's used for treating difficult aneurysms or inoperable aneurysms. It's not good for ruptured aneurysms because you need dual antiplatelet therapy. If you need rapid occlusion, it's not going to give it to you. This is something that takes, in general, 6 months, maybe sometimes a year, to achieve high rates of thrombosis and occlusion. These are some, the chart shows some of the differences in the design. Some are more supple, for example, some are more easy to push, some are retrievable, but in concept, they divert flow away from the aneurysm and provide a scaffold for endothelium to grow over the scaffold and slowly, over time, create a new endothelial layer and remodel the vessel. So let's take a look at a case example, a video of a very typical case of how we use it. This is a superior hypophyseal aneurysm. Yes, it's operable. It is a little bit low-lying. It is a long reach. You can see the distance from the bifurcation to the aneurysm. So we elected to do flow diversion. You can see we have a guide very distal, just proximal to the petrous carotid. You can see the microwire here going into the middle cerebral artery, now in the M2, M3 area, with a microcatheter tracking. This is an 027 catheter. It's a robust catheter. It's got some heft to it. Once that catheter is up, we try to bring a guide as distal as we can to provide stability and access. I tend to use only minimal things, so 2-catheter system, not triaxial. And you can see very quickly, we try to deploy this stent. We're deploying this Fred device across the aneurysm. You can see once it's deployed now, we try to bang it with the catheter and compress it. And that's really how simple it is. This was shown in real time. You can see stasis now in the aneurysm, which tells us we have excellent apposition. And these kind of cases, truthfully, we do awake and can take anywhere from 20 minutes to under an hour. So the advantages are pros. It can be used as standalone or adjunctive devices. It can be done awake. It can be done very quickly. It's ideal for aneurysms with complex anatomy that are difficult to treat surgically. Ideally used for wide-necked aneurysms, fusiform aneurysms, especially dissecting aneurysms, model very well. Ideally used in larger vessels. Of course, people are pushing them into smaller branch vessels, but truthfully, these are ideally used in the ICA, maybe the basilar or vertebral artery. Yes, people use them more distal, but they're really designed for these larger vessel aneurysms. Cons. There is a learning curve associated with them. In other words, they can foreshorten. When you have 25 millimeter devices and you deploy them, depending on the diameter they expand to, they can expand and fold into the aneurysm and foreshorten, and you may miss and require another device. You may miss proximally, you may miss distally. It requires dual antiplatelet therapy for 6 months, and we published, and we'll show you, misery bleeding or bleeding complications that are often underreported. Patients who have GI bleeding, or they fall, or they have trauma. These are real complications, especially in older patients who are on dual antiplatelet therapy. Can they be used in a ruptured setting? Yes. Is it ideal? No. Because once you put them in, if a patient needs a ventriculostomy or lines in an ICU or any type of invasive management, they're on dual antiplatelets, and that has to be managed. It can be managed, but it does add a layer of complexity. Another con, no immediate obliteration. If you feel there was a sentinel leak or this is a very irregular high-risk aneurysm, you're not going to get instantaneous thrombosis. So maybe this isn't the technology you want to use, as remodeling and endothelialization takes months. It is rare, and again, we've published on this, but there is a potential occlusion of side branches, such as a choroidal vessel or an ophthalmic vessel. It is rare, but these are things that you may want to consider if these vessels have atherosclerotic disease. So in patients who have an atherosclerotic parent vessel or atherosclerosis in these branch vessels, potential occlusion is real, and that's something you need to think about. This is the article I mentioned on nuisance bleeding when you use dual antiplatelet therapy. So basically 27% of these patients over a 5-year period, 4-year period, had nuisance bleeding. Are these fatal? No. Are they severe? No. But still, these are things you need to understand when you're putting patients on dual antiplatelets for 6 months or 12 months. They can't have elective surgeries, or if they start having GI bleeds, you have to manage this. Things to consider, pros and cons. We'll talk about combination flow diversion. The other con I didn't mention with flow diversion is once you place a scaffold across the aneurysm neck, you lose access. You no longer have access to this aneurysm from an endovascular standpoint. You do from a surgical standpoint. So this is sort of your one-shot endovascularly, and you need to consider that. So when do we use combination flow diversion, which is flow diversion with another stent or flow diversion with coiling? It's primarily performed for recurrent aneurysms that have a wide neck, so they've been previously coiled or partially stented. If these aneurysms have high concern for coil herniation, we'll coil and then use flow diversion buttress. How do we do it? This requires multiple catheters simultaneously, a catheter in the aneurysm, a catheter in the branch vessel, and a catheter in the parent vessel. So we'll show you a case, which is a pipeline and an Elvis we fondly call pelvis. So this is a case of a patient we inherited. Had a subarachnoid hemorrhage, you can see here with an interparenchymal clot, was clipped at an outside institution, was then also coiled at an outside institution. So the patient had his hemorrhage, was clipped, rehemorrhaged, coiled, and eventually was sent to Buffalo. And this is what we see here. You can see recurrence post-clipping. You can see recurrence post-coiling. This is a complicated issue now, because now it's a redo craniotomy with 2 hemorrhages and failed coiling. So the concept here was, can we flow divert this vessel, fill the sac, and protect the PCOM, which is coming off? And you can see the PCOM with my cursor. You can see it right here. So how do we do this? The first thing we have to do is access the aneurysm, and we typically like to access the aneurysm or the branch vessel in a J-shaped configuration. You can see here, the wire came up in a J and naturally snapped into the PCOM vessel. So now we're protecting that PCOM, we're protecting the branch vessel with a wire and catheter. So if we need to, we can deploy a stent or anything else we want from that catheter. So now that catheter is parked there. Once we protected the PCOM or the branch vessel in this case, you can see the run there. Our next step is to access the aneurysm, potentially for coiling. And the last step will be to create flow diversion. So here you can see we've deployed an Elvis Jr. stent in the PCOM. Right here, you can see it, we're magging up, you can see the stent. So now that vessel is protected. The next step now is going to be put in a flow diverter, but we already have access to the aneurysm with the microcatheter, so we're not jailed out. So that's a very important point. We don't want to limit our access, so we have our catheter in the aneurysm and a second catheter that's going to deploy the stent. And that's the blue arrow shows the catheter for the aneurysm. In the aneurysm, that's what we're going to coil in. The red arrows now show the deployed flow diverter. And then we can see here the stent in the PCOM. So now the last piece is coiling. The flow diverter's in, the PCOM's protected, and now we can basically shut down this bilobed, twice recurrent aneurysm. Yes, we've had long-term follow-up. This is stable in here. This hasn't grown. There is a small little bit of residual right at the confluence here at the neck, but this is very well packed. The PCOM is open. The vessel is open, and this is sort of the final configuration at long-term follow-up. So that's combination stenting, flow diversion, coiling. It is a complicated technique, but it's an important technique to have in your armamentarium. Pros. It can be used to protect any branch vessel coming out or near the neck of the aneurysm, like a PCOM or an MCA. It is an excellent bailout option for recurrent wide-neck aneurysms that require stent assistance, that have recanalized or regrown, and that and maybe a high risk for surgery, or they've had craniotomy before and you don't want to go back in. Cons, we have no more endovascular access to the branch, to the aneurysm. Now we're jailed out completely. There is a large amount of metal. We have 2 stents in this patient with a lot of coil. So non-invasive imaging is no longer an option for this patient due to all the metal artifact, and they will require dual antiplatelet therapy for a prolonged period of time. Those are the pros, and those are the cons. Sort of the next generation now of flow disruption is intrasaccular. It's been available in Europe for a while. It has recently come to the United States within the past year and a half. The device that we have here is the Webb device. It's basically a self-expanding mesh spherical device that comes in 2 forms, a ball and then sort of more of a sphere with a flat base. Bifurcation aneurysms sometimes have a flat neck, sometimes are more rounded, so you can choose the device. And you measure it basically by the width. We tend to oversize the width so it can sort of elbow into the aneurysm, and it creates length. So the wider you size it, the more length you're going to get out of it. So we tend to oversize the width by 1 or 2, undersize the height by 1 or 2, and that tends to create the best configuration. This is an early gen device. I don't believe this is where we're going to finish. And we'll talk about pros and cons as we get into this. So how do I look at a Webb? Does it meet the general Webb criteria? Number 1, is it a wide neck bifurcation device? If it's not, don't use it. Then gestalt. Does it look like the Webb device? Does it look like a ball, or sort of a ball that's flattened at the base? If it's bilobed and irregular, it's not a good one for the Webb, and you're going to get recurrence. And just like the flow diverter, you're going to be jailed out. You're not going to have a good salvage. And then we're going to have problems, especially if we try to repair this open. Other criteria, bonus criteria, if this is a high risk for surgery or contraindication of dual antiplatelet, you don't need dual antiplatelet for this device because it's not in the parent vessel. We tend to put patients on it perioperatively in case we need a bailout, but then we pull back the dual antiplatelet if we don't need a bailout, if it's well positioned. So again, let's take a quick look at a case and how this works. So here's a lady in her 60s. You can see she has an ACOM aneurysm. Reasonable for clipping. She's 60s. Reasonable for clipping. So here we come, standard configuration, transfemoral. We get the guide positioned very high. Inside the guide is another catheter, an intermediate catheter that we're bringing, in this case, almost to the ICA terminus and then into almost sometimes into the A1. Now you can see it just proximal to the aneurysm for a lot of support. This is extremely distal access. I don't recommend it early on. Here you can see the microcatheter is at the dome of the aneurysm. Now we're not pushing the device out. Now if the patient's awake, so there is some motion. It looks like it's out of the aneurysm, but she's moving. We just unsheath the device. We let the device flower. You can see it's turning into a little bit of a ball here. And once the device flowers, we then push it into the aneurysm and use the intermediate catheter to flatten the base. So you can see this little area here. I'm going to just come back a second. This little area here is the base. This is the tip. It's flattened out, which we used the intermediate catheter to do. And then you can see stasis. Again, you don't have immediate thrombosis. We don't have any overhang in the parent vessel, so she doesn't have to stay on Plavix. Pros of this device, no dual antiplatelet. She's 60. Ideally, we don't want her on dual antiplatelet. So now she just stays on aspirin. There's no stent in the parent vessel. It's great for high-risk surgical aneurysms. She wasn't a high risk. She's only 60. This is very suitable for clipping. Patients are drivers of these technologies, so when given the choice, she's electing not to have a craniotomy if it can be avoided. It does require good judgment and case selection. As I said, if it doesn't look like a round ball, probably not ideal for this technology. So truly, there's a subset of patients that are ideally suited for this, that they truly have round bifurcation or bifurcation aneurysms with a flat base. They're not multilobulated. They're not elongated. So that's ideally a smaller subset than we think. If you get recanalization because you didn't have good apposition, or you selected the wrong size, or it wasn't a great aneurysm, it is a problem to repair endovascularly. It is a challenge, and that needs to be considered up front. Dual microcatheter coil embolization. Why do we use this technique? As we started our discussion 10, 15 minutes ago, we said in the setting of a ruptured aneurysm, we don't like Plavix or Brilinta or any dual antiplatelet in case you need ventriculostomy, central lines, or other interventions during the ICU period. So if we can avoid putting in a stent, we want to. So what do we do with wide-necked aneurysms that maybe we don't want to operate on or are high risk for operating on? So this involves placing two catheters simultaneously and using a Russian doll technique, but intertwining one coil mass with the other coil mass. So you're basically de novo and in situ creating a mesh scaffold at the base of the aneurysm, where one coil would just herniate out. The two coils simultaneously placed intertwine with each other, and you actually create your own mesh across the neck. So it's a great alternative in the setting of ruptured wide-necked aneurysms. Let's see what it looks like. So here you see a CT scan. You see a typical subarachnoid hemorrhage. Here you have the CTA of that CT scan showing a wide-necked, bulbous PCOM aneurysm in a relatively older person. Let's just say high medical comorbidities. We don't want to operate on this patient. So step one, first microcatheter goes in. You can see our guide placement here. Microcatheter over a microwire coming into the aneurysm right there. We park that. So once we feel we have good, stable configuration of that catheter, we will now bring in a second catheter. So here's catheter 1, here's catheter 2. So you can see that the catheters are both in the aneurysm, but at different places. One's a little bit deeper. One's pulled back maybe a third of the distance from the top of the dome to the neck. You can see this patient's awake. They're moving. We tend to do most of our aneurysms awake in Buffalo. We've shown that that tends to give us a little bit of a better outcome because we're not anesthetizing and we're not dealing with blood pressure shifts, and we can monitor the patient. Obviously, if they're a poor grade or a very small aneurysm where they can't hold still, we're not going to do them awake. But now you can see the two coils, the one basket interweaving with the other basket. So this coil is coming up here, weaving into this part. This one's partially deployed. This catheter is fully deployed, the coil. And once that one's fully deployed, we started with this one. Now we'll go back and we'll continue to coil what was partially deployed. So you can see this catheter here is empty. This catheter here is finishing very long coils. We tend to use very long coils so you can create this mesh weave together. Here we come, finishing this coil. And we continue, and I'll sort of fast forward this to the last coil. You can see we're sort of struggling to get this last coil in. And I believe we decide not to put it in. And the enemy of good is perfect. Once both catheters come out, we'll do a final injection. And you can see no stent, wide-necked aneurysm, excellent coil occlusion of this aneurysm. No need for dual antiplatelet. Truthfully, no need for aspirin if you don't want that either. So pros of the dual catheter simultaneous coil technique. Of course, it's faster because you're deploying two coils at the same time versus one. It's ideal for wide-necked or bilobed aneurysms. You can coil both of the lobes simultaneously. So heart-shaped aneurysms, for example, similar to this one. You're creating the framework. You're actually creating that mesh across the neck versus just coil loops. You're developing coil intertwined with coil, so you're creating a fabric or a mesh to prevent coil herniation. You decrease the X-ray exposure because you're working 2 times as fast, 2 coils at the same time. Of course, you still have the risk of coil loop herniation. It's less, but it's a real risk. Balloon, for example, balloon occlusion, temporary balloon is the only way not to risk it during the coiling. It can occur after. You can have obstructive flow because you have 2 catheters. So if the vessel is small anatomically and you have 2 large catheters in, you have more plastic in the lumen, so you can create ischemia that way. So one reason we like to do these awake. Without a stent, you have a higher potential for recurrence in wide-necked aneurysm, and the data has shown that. So in my remaining minutes, I want to talk about a concept that we've done here a few times called temporary coil occlusion, which is very similar to temporary clip occlusion in the setting of a ruptured aneurysm. We temporary clip if we want to decompress an aneurysm, make it softer, but certainly we clip parent vessels in the setting of an intraoperative rupture. So what does that look like in the setting of endovascular? It's a bailout option for intraoperative ruptures. It's similar to surgical clip placement, and it takes no time. So typically when we have a rupture in the endovascular setting, we bring up a balloon, we got to pull the catheter out, prep a balloon, bring up a balloon, and all this takes time. And while this is happening, whether it's 5 minutes or 10 minutes, whatever the time is, the patient is bleeding into the brain. The aneurysm is ruptured and bleeding. But you already are right there with a microcatheter. So what can you use if you have a tool right there? Why not take your coil, don't deploy it, just deploy it in the lumen proximal to the aneurysm and shut off your flow. Create a cork right there, reverse the heparin, and then slowly pull it out. And usually just that alone is enough to create a temporary thrombosis and stop the bleeding. So let's see what that looks like. So here's a pica aneurysm that came in ruptured. You can see there is there's a coil loop outside the rupture site. There was a little lobe there where it was probably the rupture site. You saw the extravasation. Let me just go back to that a second. I think it's important. So right here is the rupture site. Now we have a loop that goes out. And now we have extravasation clearly there. So we have a catheter there. Let's not take that out, prep a balloon, load it, put it in. The patient's bleeding. So we take a coil, the catheter's right there. Just take the coil and put it in the parent vessel. In this case, we put it in the vertebral artery. You can see there was no more extrav, and I'm going to show that little run again. No more extrav, and now we wait. We're fine. We reverse with protamine, reverse the heparin, slowly pull the part of the coil out to see if there's any extrav. There isn't, so we pull half the coil out. Now we're going to retrieve the rest of the coil. Again, we're doing this slowly. Now you're there. We're just going to put the catheter right back in the aneurysm. We're going to take that coil that we just used as temporary occlusion, and we're going to finish coiling the aneurysm. So we had minimal time of extravasation, minimal time in between. And usually, we've done this now a handful of times, it has worked very well. So pros of that, provides instant proximal control, very similar to temporary surgical clip application. It's fast because you don't have to get anything new. You're proximally there with your devices, and you just have to move millimeters. You don't have to change your catheter. And then once you got stasis, you can continue with your endovascular approach without conversion to an open procedure, ideally. Cons, you lose your aneurysm access because you pulled your catheter out, which you would anyway. You have a thromboembolic risk from the coil. You get stasis in the aneurysm, but you can also get potential stasis in the parent vessel and cause thromboemboli. Now, we've done this 3 times. That has not happened yet, but that is definitely a risk. So you need to monitor this very carefully. And then patients are not fully heparinized due to their subarachnoid hemorrhage, so that's the thromboembolic risk. And I think with that, I will be respectful of my time. Again, Jacques, I thank you very much.
Elad, that was very nicely done, very clear. You were able to reach, I think, the very young who are not too familiar with this, and then the very experienced as well. Just a quick clarification on the last method you discussed, just to make it clear. You mean you deploy it when it's an unexpected problem, correct? Because otherwise, I've had a question from the audience, why not do balloon remodeling from the start? Maybe you could address that.
Great question. So you're not expecting an intra-op rupture. You're coiling, and then the coil loop goes through the weak spot of the ruptured aneurysm, and you see extravasation. Your choice there is to take everything out and bring up a balloon to arrest flow, and that's going to take you, in the best of hands, 5-10 minutes. And during that time, you're extravasating. So all you need to do is just move your catheter a millimeter and temporarily deploy the coil in the parent vessel. It's not something you do up front. It's a bailout salvage maneuver, just like when you have a rupture in the operating room. You quickly throw a clip on the parent vessel and any branches that may be leading to extrav. And then you temporarily get control, you get hemostasis, and you remove your temporary clips. It's the same. This is the endovascular concept of that.
And a question from me, Elad, how much of the vessel do you coil it up till total arrest, the parent artery, or just enough to really slow down the flow with the coil?
Exactly, just enough to slow down the flow. So we take a very long coil and we deploy maybe a third or a half of it, and we do an angiographic run. If we don't see any more extrav in the aneurysm, but there's flow going through the vessel, we sit tight. That's exactly right. If there's still extravasation, we'll deploy a little more coil. So we just deploy enough to stop the extrav from the aneurysm and hopefully still allow flow around the coil in the parent vessel.
Great. Thanks a lot, Elad. If you don't mind, stop sharing your slides, and I invite Rafael to unmute his microphone and share his slides.
Jack, can you see my
We
my
see
slide?
you and hear you very well, Rafael. Thank you.
And you can see the slide?
Very well.
Okay, great. Well, first of all, it's a tremendous pleasure to be here, Jack. It's great to be able to spend time with you.
Sorry, your
and-
video's off.
Sorry,
Turn on your
Rafael,
video.
you turned off your video unless you don't want us to see you. Turn your video back on. I don't know. You're using an iPad?
Yeah, I'm using an iPad. Yeah. So yeah, you don't need to see my ugly face. So.
Well, it's up to you, but just to let you know, we can't see you now while
Okay,
you're presenting.
okay.
That's okay. It's up to you.
So I'll discharge the sign language person I had. So anyway, so
Okay.
anyway, Jack, it's a pleasure, and it's a pleasure to spend the time with Elad, Nilesh, David, and Errol. So what I want to talk about is just review what are the current indications for open microsurgery, and what is clear now an endovascular era for aneurysm treatment. I have no disclosures. And basically, this is a type of aneurysm that we're considering now, a wide neck MCA aneurysm incorporating both M2s, and it's a kind of aneurysm that that presents a challenge for endovascular, and there are great advances going on now. Just to review quickly how clipping evolved. So as most of you know, the first clipping was done by Walter Dandy on March 23rd, 1937. It was a 43-year-old man who had presented with a 5-week history of diplopia and ptosis. And once Dr. Walsh, the ophthalmologist, told him that he thought it was a compressive oculomotor problem, Dandy explored him and found a PCOM aneurysm that he clipped using the little bending wires that had been developed by Harvey Cushing. The field then remained in its infancy until the 1960s, when the microscope was introduced. It was introduced through ENT, and then brought into neurosurgery. And this was a paper by Dr. Lawrence Poole at Columbia, announcing the use of the dissecting microscope for vascular surgery. And that was in 1966, roughly 30 years after Dandy described the clipping of the aneurysm. Things that moved fairly quickly, and the standard bearer, as you know, is Dr. Gassi Yassergil, who in 1972 published this paper with Hugo Krayenbuhl, announcing the microsurgical treatment of intracranial aneurysms, and this is a book that most of us were brought up on, published in 1984. So in a period of about 40 years, the field blossomed into pretty much where we are now. This led to a tremendous success in the treatment of ruptured aneurysms, and this was unveiled for the medical community in this article in the New England Journal by Dr. Thor Sunt at the Mayo Clinic. It was an article published in July of 1978, where, as you can see, in the preoperative management, they admitted 310 patients. While they were waiting to operate on the patients, 30 of them died. This was at a time when it was still thought that it was important to cool off the patients. But the results were really, of the survivors, the results were really good, with a mortality of 1.7% for grade 1s and 35.2% for grade 4s. And again, this using the Botterill grading system, not the Hunt and Hess. So now Elad has shown you a beautiful review of the endovascular field, but just very, very quickly from a historical perspective, modern endovascular aneurysm treatment started with the Guglielmi detachable coils. When Dr. Guglielmi went to UCLA between 1990 and 1991, developed with Dr. Vinuel and Dockweiler, the GDCs, and then published these two remarkable papers in Journal Neurosurgery in July of 1991. It was published in two parts, announcing the introduction of the coils. As things became complicated with the coils, then the next big step was in the resolution of this challenge of how to have what kind of stent could be used that could close enough of the aneurysm but allow the perforators to survive, and that ratio, people worked on that ratio for a while, and then this resulted in this other phenomenal development, the pipeline. And as Dr. Levy mentioned, at this point there are many other of these type devices like the Surpass and others. The first experimental study was published in 2007, first clinical case reports by Dr. Fiorella and his group in 2008. And then in 2009, we had the first large series, Argentinian series of 53 patients, which was the one that caught my attention and that of my endovascular colleagues. And then, as Dr. Levy mentioned, recently there's been another dramatic step taken by the woven endobridge, the web device. It is for wide neck intracranial aneurysms, first reported in 2011 and FDA approved in 2018. So taking a little bit of a step back, we see that initially when the only endovascular device available was the coil, this led to this very large trial, the ISAT. It was first published in the Lancet in 2002. Now I had the good fortune of finding out the inner workings of the ISAT because Hopkins was the only center in the United States that participated in ISAT. There were centers in Canada, but Kieran Murphy and Daniele Rigamonti were respectively the interventional neuroradiologists and neurosurgeons that were approved for the study. So the trial was first published in 2002, and then the most recent results were published in February of 2015. Now, the problems with the trial was that that there were issues with recruitment of patients and then follow-up. In the 43 centers, there were 9,559 patients that were admitted with aneurysms, and because of the way the trial was written, 78% were excluded from randomization, and then 22% were randomized. By 2 months, there was already an 11% dropout, and at 10 years, they were able to analyze only 1,644 patients, which is a 23% dropout. So the trial the conclusions were based on only 17% of the patients from the original group. One of the other issues was that the requirements for entering into the trial were more strict for endovascular neurosurgeons and neuroradiologists than for open neurosurgeons. And as a result, it has been felt that the expertise of neurosurgeons in the ISAT trial was not at the same level as the neuroradiologists. And then, most importantly, they published initially the retreatment numbers, but then stopped publishing them, and the retreatments are not available at the 10-year mark. Now, very early on, there was this paper by Campi that addressed the issue of retreatment. And what they showed was that by early on in an average of about 1.7 years after the trial, there had been a retreatment rate of 17.4% for the coil patients and 3.8% for the surgical patients. And then the rebleed rate, although small for both groups, was similar. And this led to the question of whether rebleeding could overturn the what was perceived as a superiority in this trial. The 10-year results were published in 2015, and again, there's no data on retreatments, but the rebleed rate was 3 times higher in the endovascular group than the neurosurgery group. And then we went into the BRAD trial, which is another landmark trial by Cameron McDougall, who is one of my 2 partners at Hopkins in endovascular now. The other one being Justin Kaplan, who trained at the University of Miami with Eric Peterson, and this the BRAD trial was it's a very interesting trial, very important trial, but one of the problems with the trial that, as most of you know, the coil to clip crossover was 36%, and the clip to coil crossover was 1%. So the 10-year results of BRAD, which were just published in March of 2020, showed that the extent of aneurysm obliteration was higher in the clipping group, that the aneurysm recurrences and retreatments were higher with coiling, but the good outcomes were equivalent in both groups. And this is what you see here, that the 10-year results show that the MRS scores are essentially identical for microsurgery and endovascular. The number of deaths are the same, but then the retreatment rate in microsurgery was only 0.8%, but in endovascular, 20%. And that goes along with the complete obliteration. Over time, the complete obliteration rate for the microsurgery group went from 87 to 93%. It increased, but with coiling, it went down. So what you see as the retreatment rates, and I think looking at the retreatment rates is very important, assuming that the morbidity and mortality of both techniques are comparable, and which they are. But the retreatment rates, in my mind, are a proxy for significant recurrences. You know, enough to worry the practitioners to the point that they recommend retreatment. So then you see that that basically ISAT at 1.7 years was 17%, BRAD at 10 years was 20%. But then the question comes up, but are these numbers really relevant today, since we now have gone beyond coils and we have pipeline webs and all these other procedures? So the literature gives us a glimpse at what's going on, and that is, you know, how is the pipeline holding up so far? And there's a paper from the University of Utah that is based on the Premier Healthcare database, which is a very large 8-year database. It was just published in June. And what it shows, it compares the retreatment rates at 2 years for pipeline embolization and non-pipeline embolizations, which include coils and other things. And as you can see, at 2 years, the retreatment rate for non-pipeline is very similar to what was reported in ISAT and then BRAD, 14.7%. But the pipeline has a lower recurrence rate, but still a rate of 8% at 2 years. And that's where we are. So then, how is the web holding up? Now, the web is being increasingly used now in the United States. In Europe, they had more experience with it. But this is a paper that was published mostly by the European group, reporting the early results of webcast and webcast 2. And what they show is that the retreatment rate was evaluated in 88 aneurysms, and they show that 11.4% of the aneurysms have recurred and had to be retreated. So what we see is that these technologies, even though they have been tremendous and have really assisted in lowering the mortality and morbidity for our patients, remain with a concern of the retreatment rates. Now, one of the problems that one of the issues, one of the ways to look at this is through the Gardner curve of technological innovation. Now, Gardner Inc. is a global research and advisory firm in Stamford, Connecticut, and someone there came up with this Gardner curve that is associated with any technological innovation. So they point out that any new technology goes through 5 phases if it is successful, and that is that you have the technology trigger when the technology is introduced, and that, you know, the enthusiasm is tremendous and it reached the peak of inflated expectations, but then people start seeing problems, and then you hit what they call the trough of disillusionment. But then from then, you know, the technique is valuable, like all these techniques are. You enter the slope of enlightenment and then the plateau of productivity. I should point out that this is a curve that can be used for many things in life, including hobbies, girlfriends, marriages, but that's another story. But anyway, so basically the endovascular field is progressing along these lines. But interestingly, the way that I interpreted it is that, for example, with the GDCs, you have the trigger, the introduction of GDCs in 1990 and 1991. And then as we were, you know, becoming aware of the problems with the GDCs and then starting to reconstruct, then the PV and similar devices were introduced. And then you have a new trigger that now starts riding on top of the GDC wave. And then just as we start to find out the limitations of the pipelines and similar devices, then we have another trigger which is occurring earlier in the whole evolution of the field, which is the web. And then so then what you see is this curve where essentially the field is improving and the enthusiasm is increasing, but where it's going to end up is anybody guess at this point. How has our practice changed at Hopkins? Well, this is a graph of the last 30 years at Hopkins, and you see that in 1991, like everyone else, we were clipping all the aneurysms, and then with time, the percent of aneurysms that are clipped has decreased. The endovascular aneurysms has increased. We were very impressed with the initial Brett results, and as a result, you see that in 2012, we reached a point where both techniques were used equally frequently, 50%, 50%. And then over the last several years, we've had an increase in the endovascular treated aneurysms. So at this point, 80% of the aneurysms at Hopkins are treated endovascularly, 20% are treated with surgery. So what is the state of the art? And if you go around the circle of Willis, this is, of course, this is my perception of the field with the biases inherent to my practice. But as you know, as director of vascular at Hopkins, I just want the patients to come over and get the best care. So we're still treating a lot of ACOM aneurysms open. Similarly for MCA bifurcations, the PCOMs can go either way. Bacillus apex have gone primarily to endovascular treatment. We're still treating a lot of PICAS open, and the clinoidals, ophthalmics, and superior hypophyseals we treat primarily endovascularly. In terms of ACOMs, what is the argument for continuing to clip the aneurysms? Part of it is that the surgical results are good. Now, this is a paper that is going to come out in operative neurosurgery by Eric Nussbaum, whom most of you know. He works in Minneapolis, Minnesota, and has been doing outstanding work for many years. And he has his personal series of 300 cases with a 1% death and poor outcome. All the other patients have done well. This paper is also very interesting because he and his colleagues did a literature review of unruptured anterior communicating artery aneurysms, and they found 14 major surgical series with a total of 865 patients and 7 major endovascular studies with 430 patients. Now, granted, all these are series in which people are putting their best foot forward, but again, the results of microsurgery and endovascular are similar. No difference in the literature there. Complications are the same. The deaths are the same. But again, the problem of complete occlusion comes up. In this study, there were complications that were unique to microsurgical treatment, like subdural and epidural extradural hematomas, cranial nerve palsies, and anosmia, which some patients complain bitterly about. And then in the endovascular treatment, there were bleeding from the antiplatelet regimen, subarachnoid hemorrhages, and coil protrusion. The MCAs are in a similar position where we everyone is exploring how endovascular can be used for treatment, and then this is a fascinating paper which is just came out in Journal Neurosurgery, and it is two papers. This is from France, and these are 2 hospitals. The way I read it, they're both in Angers, France, in which one hospital, the doctors have a clip first policy, and in the other hospital, they have a coil first policy for middle cerebral artery aneurysms. And the 2 groups are of equal maturity and again highly skilled, and you can see the results are very similar, except for the fact that already by 24 months, the number of retreatments and coiling is higher than clipping. The results in terms of deaths and outcomes are very similar. In the ruptured aneurysms, the death rate was a little higher for coiling, but the MRSs were better for coiling, and the unruptured aneurysms, the deaths were greater for clipping, but then the MRS were better for clipping as well. So basically, this leaves us with a very complicated algorithm. And the way that I see it is that the decision of whether to pursue clipping or coiling is based on 3 major areas: patient features, aneurysm features, and a couple of anatomical issues. So in terms of patient features, if you have a younger patient with minimal comorbidities, or you have patients that have a contraindication to use antiplatelets, or patients with difficult arterial access, or patients who strongly prefer not to have a scar on their head, but microsurgery is a good option. In terms of aneurysm features, I think that it is clear that, in my opinion, that for clinoidal and basilar aneurysms, endovascular techniques are better. I think that for MCAs and ACOMs, particularly at bifurcations, clipping is still better. For small aneurysms, I think we can deal with them better with clipping than with coiling. I think that an indication for microsurgery is a double recurrence, a double or triple recurrence after endovascular therapy. And then the wide neck aneurysms, at this point, I think are still in the realm of microsurgery, although the web is a tremendous advance. And then there are a couple other anatomical factors, and that is that if you have a patient who presents with a hematoma with mass effect after rupture of an aneurysm, then that tilts things in favor of microsurgery, because you can evacuate the hematoma at the same time that you do the surgery. And then patients that have an oculomotor neuropathy, we published a paper on this showing that the recovery is faster and better with microsurgery. So in summary, the microsurgery has at this point the advantages of lower recurrence rate. In my opinion, follow-up after 1 year is rarely necessary, assuming that you did an intraoperative or an angiogram soon after the clipping, and there are no long-term medications. The disadvantages is that it's clearly more invasive, and the procedure has the drawbacks of infections, and then temporalis discomfort, anosmia, and then the recovery period is 6 weeks for ruptured aneurysms. Endovascular is a less invasive intervention. You just can't beat a little hole in the puncture at the puncture site in the radial artery or the femoral artery. The recovery is for ruptured aneurysms is dramatic. Patients go back to work 1 to 2 weeks after that. But the disadvantages remain the recurrence rates, which necessitate, at this point, lifetime follow-up with repeat imaging, including catheter angiography. And this is the algorithm that I use for this. So in conclusion, despite tremendous and very impressive advances in endovascular, which have led to the fact that most aneurysms are being treated this way, open microsurgery remains an essential technique for aneurysms. Endovascular advances over the past 30 years have been impressive, and they continue at a very rapid pace with tremendous innovation. But aneurysm recurrence and rupture have been, since the beginning and remain at the present, the major concerns about endovascular treatment, which at this point requires close and ongoing clinical and radiological follow-up. And the retreatment rates remain, in my opinion, the best way to measure, the best measure by which to assess the efficacy of aneurysm treatment modalities. So, so let's see, I'm going to stop sharing.
Very good. Excellent.
Yes, thank you. And okay, so is the screen okay again?
Yeah, we're good. Very nice, comprehensive and balanced view of where we are today, I believe. And let's see what the various panelists will say about those two presentations. So thank you very much, Rafael. Let me invite Nilesh, one of our first panelists, to share his screen and perhaps use a case to get some discussion going.
Well, excellent talks, Drs. Levy and Tamargo. really enjoyed it both. Thank you, of course, Dr. Morcos, for the invitation. Can you see my screen okay, everybody?
Yeah, it's good.
Yes.
Well, this is a case pretty straightforward, I think, but you know, a little bit of some nuances to it. A case of mine from a year ago. I don't have any conflicts to disclose. So the clinical history, this is a 49-year-old woman who was an avid runner, an ultra marathon runner, who developed a severe sudden onset of headache. Actually, after she had run 6 miles, after the headache started, she went on to run 2 more miles, but then finally decided to stop after her 8th mile of running. She was initially taken to one of our health system hospitals allied with my tertiary care referral center, and she got this head CT that you can see at the right. She was a HUN-HES grade 2, very healthy without a past medical or surgical history, and neurologically on exam, severe headaches, but otherwise neurologically well. CTA performed upon her arrival showed possible small anterior communicating artery aneurysm, and so she underwent an angiogram, and that was negative. And so our habit has been with typical non-aneurysmal perimesencephalic hemorrhages that we may not even repeat an angiogram, but with this story and with this head CT appearance in particular, we of course chose to get the formal angiogram again 1 week later. She remained in the intensive care unit, remained neurologically well, fortunately did not have a re-rupture. The repeat angiogram did show a very small aneurysm just beyond the basilar apex on the left P2 segment. And even in retrospect, looking at the initial CT angiogram and catheter-based angiogram, which you see here, both the first angiogram and CTA on the left, and then the second angiogram and CTA, really just this little dot on the AP angio is what we're really looking at. Almost easy to miss, and just a little double density here, and obviously the arrow on the CTA showing the showing that aneurysm. And so I would ask our speakers, how would you treat this?
Well, maybe Elad, can you address maybe a couple of issues? Well, how do you handle a angionegative hemorrhage with this kind of Fisher grade? And then maybe what's your protocol at your center dealing with those cases? And then second part, maybe Nilesh, direct question.
Yeah, so typically, you know, if it's angionegative and looks like a pretruncal subarachnoid or perimesencephalic subarachnoid, we're going to be less aggressive. But as Nilesh pointed out, this has blood going all the way out to the fissure. The CT scan looks much more angry and aggressive than your typical perimesencephalic hemorrhage. So your suspicion has to be high that there is that this is arterial. And I think in that setting, we typically would treat them in the ICU with subarachnoid hemorrhage protocol, and then we would repeat the angio not too far in the future, 3, 4, 5 days. And then if it's negative again, we will do one more prior to discharge. But usually between the second and third one, if there is something there, we will see it. Now, it's hard for me to see that aneurysm on the pictures that you show, just the way it's small on my screen. I'll try to make it bigger. So then the question you now have to ask yourself is, do we think that that aneurysm was the cause of this bleed, right? That little 1 millimeter P2 aneurysm, it could be. It could be, you know, pretruncal. It could go out the sylvian fissure. So I think it could be. I definitely would want to take a better look at that, per se. But if we thought that that was the cause, and I think this needs to be treated, I just can't really make out that 1 millimeter aneurysm. I will also say that aneurysms of that size in general are extremely high risk for coiling, and we've published and other centers have published it. Once you break the 4 millimeter barrier or the 3.5 millimeter barrier on the underside, that increases your risk of coil complications. And so in general, those are higher risk aneurysms to coil than the larger ones, because there's not a risk, there's not a lot of room for catheter manipulation.
Elad, are there any angio tricks to improve visualization of those things? Should he have done an Alcock test? What tricks, what endovascular tricks do we have to improve visualization of those tiny ditzels?
Great question. So high res, high mag, 3D angio. Some people have microangio. There are a few centers we have microangio. I don't know if you have microangio, which gets down to 60 micron. It's a special fluoroscope. But in general, did you end up doing a high mag 3D rotational?
Yes, we do have more views, which I wasn't able to, put up on the PowerPoint. But yeah, Magdin views and obliques, other angles. None of them really showed it very much better because of its size, but the 3D angio did show that it was, a round dome-shaped aneurysm just on the back wall of that P2 segment posterior to it.
So I don't think, I don't think this is one that is great for endovascular unless you're going to lay a flow diverter across it. But now you're sort of off label, so you can. I think this is one that if you feel this was the cause, then it's worth micro exploration surgically. What do you feel, Raphael?
Yeah, so I agree. The hemorrhage, I agree with Elad. The hemorrhage was very suspicious. It doesn't look like a perimesencephalic hemorrhage. I think it's interesting that the hemorrhage was mostly on the left side, and then you found this little abnormality on the left side. But then again, there was a 50-50 chance that it would be there. But I think that I can't see it very well, but if with the other views and all that, it looks like a convincing lesion, I think it would be reasonable to explore that and do and clip the aneurysm if that's what it is. One of the things, one of the pitfalls of little aneurysms in this area is to make sure that you're not dealing with a PCOM reverse infundibulum, or an infundibulum of the basilar perforator. So I've been, fooled by those. But if it looks like an aneurysm, I think it would be a good case for surgery.
Can I maybe, as a way of welcoming Errol, I don't know, can you hear us? Can you comment on how you would handle this case?
Yeah, so I agree with a lot. I mean, I think it is a little difficult to see it. And I'm sorry, what's the time frame from the original angiogram to the second?
6 days.
6 days, yeah. So, I mean, I think this is a classic case. The old school way was 3 angiograms, 1 week, original 1 week, and then 6 weeks later. A patient like this, that blood pattern clearly is not, that's aneurysmal. It's not perimesencephalic. It's predominantly in the Sylvian fissure. But something just doesn't fit here. And my litmus is always, if it doesn't fit, kind of sit back and think a little bit. I would repeat an angiogram, probably even in 3, 4, 5 days. It looks like there's a little spasm along that basilar trunk, which I think is also going to kind of falsely tell you that this is smaller than it probably is. I don't know that I would start off with an operative exploration, but if this is clearly the only thing you see after another angiogram, I would say 3 to 4 days from this, maybe even up to a week with ICU aneurysmal protocol, hydration, trying to avoid spasm here. And if you still see this, and certainly it's bigger, I would do a surgical exploration. But I would really want to see that MCA well as well in the anterior circulation on a repeat angiogram.
Does any of you on the panel, the speakers, still have any use for Amicar in rare instances where you know you want to sit tight on a hemorrhage, like a case like this? Can you comment on that to prevent rebleeding?
We haven't used it. I haven't used it in a long time. And I think for something like this, I think she's fairly, you know, she's far enough out. You know, she's going on. I don't know what it is.
6 days.
Later.
6 days. She's
6
had
days, yeah.
vasospasm, you know, peak, but
One of the
anyway.
people typed a question, and I typed an answer back. They asked why not flow divert it. And this is a small, I'll use the term blister. It's not technically blister, but this is a ruptured shallow aneurysm. And as we talked about before, flow diversion is not going to give you instant thrombosis and instant remodeling. So this patient will still be at significant risk for a rehemorrhage. Sometimes we'll flow divert and put coils in to stop, you know, to hopefully buy time and create thrombosis, but this is too small to safely coil, at least from what we see here. So that's why you know, somebody asked, why did I say microexploration? It's for those reasons. Flow diversion is really a suboptimal choice in this setting.
Elad, I have a question. Would you ever consider during the first or second angiogram, taking the microcatheter over there, just park it close to the, you know, what question be an aneurysm, and then do a small injection, because it will define it like Raphael said. It could be infundibulum, reverse PCOM, it could be infundibulum for a perforator. But if you do a micro injection, you subtract all that, you're very close. You're not intention to go inside the aneurysm to treat, but just to get a really...
Nick Hopkins, obviously the former chair and my mentor, was a big fan of that. He said, look, if you can't sort it out because you have dye being sumped to the other PCA and SCA and pica, he said exactly that. Take a bigger microcatheter like an 027 or something like that, and just get up into that P1 and give an isolated injection, and that will really help clarify it. And that's a great point that you make. So just before you do microsurgical exploration, he used to call it microcatheter exploration, just proximal to the lesion. And that helps to really sort of focus your view and clarify things, to the point Raphael said about an infundibulum or reverse flow from a PCOM or something like that. It's a great point.
Nilesh, carry on with the story, I guess.
Well, we considered all of that. You know, the images I wasn't able to show without, you know, boring everyone with 1,000 slides were the other images of the angiogram. You talked about the MCAs. She had very nice vasculature, no spasm, especially for the first angio. And, you know, we could see all of the normal bifurcation locations for aneurysms and saw nothing. That narrowing of the basilar, I think that's actually a little bit of washout from the contralateral vertebral artery. So her basilar looked pretty good, and she did not have significant spasm, you know, either on the angiogram or during surgery when we went ahead and talked to her a little bit about, you know, whether this might just be true and unrelated, a atypical head CT appearance of a perimesencephalic non-aneurysmal subarachnoid hemorrhage, 50-50 chance that the Sylvian Fisher blood would have been on the same side as a very small aneurysm. But given that she was doing well, no spasm, very healthy, felt that an exploration would tell us the most information about what is really going on and whether this was a ruptured aneurysm or not. And so did a subtemporal approach. You know, if you, I actually used, which I almost never do with aneurysm clipping, of course, used navigation and did a subtemporal approach so that I could get right to that spot kind of as a funny location, not at the basilar apex. Did a subtemporal approach and did this intraoperative angiogram after the clip was on, confirming that the double density that we had seen was gone. When looking at the aneurysm, it was interesting. Half of it was inside of the PL surface of the midbrain, and half of the neck half was still outside. There was some blood right around the aneurysm at that point. I don't know for 100% if that was really the just blood layering around from a perimesencephalic vein, or if it was from the aneurysm. But 6 months later, she ran her 100th marathon, and she's been happy ever since. So whether I did the right thing or not, I don't know, but we've had a fortunately good result for her.
Oh, well, that's interesting. That's very good. Nice. Yeah, I mean, the subtemporal approach, you know, it's simple approach. If the lesion is not too high, certainly if it is low, it's the forgotten approach of Drake that people kind of probably don't know how to do anymore, but I'm sure Raphael will agree. Nice work, Nilesh. Thank you. David, let's invite you to show your case. Let's see if there are any questions about this. No, I don't see any questions from the audience about this right now.
So again, thank you, Jack, for inviting me. It's really an honor to be among you guys and share some of my cases here. This is my way of disclosures. This is just an emphasis to till today, over 12 years, and Jack can make all jokes. He's a close friend. He'll tell you it's still learning, and it's a journey, and it's a fun journey to learn. You know, between, and I like Raphael's presentation, that slide. It's really good about how we progress in new technology. So my case is a 30-year-old female. She's given birth for her first child while she's given it in a local hospital. She had severe headache, worse headache, and lost consciousness. So immediately they rushed her. They did, the baby was decelerating. So they did a C-section, took the baby out, and then they got this head CT. We didn't see any they sent it in to me immediately. I'm sorry. This is the CAT scan. They thought it was not a subarachnoid hemorrhage. You saw this, but they did LP. It was also negative. I asked them to do a CTA, and this is what they found in the CTA. This mass, just to kind of for you, this is an MRA. We do in our hospital as part of research, and I would encourage the guys, you know, to do it in cases like in the first case. If there's a question, you do vessel wall imaging and QSM. We'll be able to use QSM to detect microbleed at the interface between microaneurysms, the aneurysms and brain tissue and sentinel headache. This is the vessel wall imaging. We have a big study on it, but you could see the enhancement of this. This is another image of it. This is the QSM, which is at two faces. You can see microbleeds. Really, if you at the real interface, even if the head CT is negative, the LP is negative, especially sentinel headache, you could see like a yarmulke, if you will, of hemorrhage at the top of the aneurysm. We published on it, and it's there. This is the angiogram. We did. There's nothing filling from the right.
That's a great description, David.
Huh?
I said that's a great descriptor. It's a great description.
Yeah. The yarmulke. Yeah. Yes. This is the angiogram. There's not filling from the right. From the left side here, you could see this the jet flow in, and you could see the next graph is later filling of the both ACAs. Again, here you see an image of that, and this is the image. Again, you could see right here both ACAs coming out of the aneurysm. They're about 1 centimeter apart from the inlet of the flow, if you will, and then the outlet for both PC. This is the micro injection. Again, I like to do that just to kind of understand the anatomy for me and see here. So the first one you could see right here, you see the arrow. That's where the A1 comes out and then give you both AC. I'm sorry, it's kind of faint, but that's how it is. This is the one in below can show that too. The one on the right, the top right, you could see that blip, and that blip comes from it is the A1, the distal A1, and both ACAs. So if you will, this is more like a true A1 aneurysm. Okay, that's the case.
And David, the right injection shows absent right A1?
Absolutely nothing except MCA filling. Patient, by the time she got intubated, she arrived to our hospital. She's comatose. Part of it because of the the sedation. We did an echo because of blood pressure. Her cardiac output was about 20 to 30. And then she gained her consciousness. She was grade 1.
The baby had been delivered already, David?
Correct, sir. It was sorry, I had to go. It was delivered by C-section, as I mentioned.
Okay.
While it was they did a good job. It was impressive for a small hospital. Safe
Okay.
baby, the weight is good.
Rafael, take this one first.
So I'll tell you, my sense is that this aneurysm needs to be taken out, okay? Because whatever trouble it's causing, the mass effect alone is significant. Now, one of the things that I'm impressed by is that it's supplied only by the left A1, and the flow, at least from what we were shown, the flow into the A2s is not very good, and this is not unusual for these single supply giant aneurysms. Now, this lady may not need the left A1 anymore. There could be excellent collaterals supplying the distal anterior cerebral artery, and one thing that that you could consider is going in, putting a temporary clip on the A1, checking your SSEPs, and just taking the mass of this aneurysm out, doing an angiogram, and if you find good flow into the ACAs, maybe call it a day. The alternative is, and it's what I would favor, is trying to do a bypass. And what I would consider is doing a radial artery graft, connecting it to the STA, and then going into the interhemispheric fissure, and where it would be a little more comfortable, and have larger size vessels to do either side to side or maybe end to side. There would be a very big discrepancy to do that. But I think that the aneurysm should be removed. It's just huge, and whether to do a bypass or not, I think you can go through the first analysis, but I think to be on the safe side, I would favor a bypass using a radial artery graft into the interhemispheric fissure.
Elad.
So I'm going to go the other way on this. I think, David said there wasn't subarachnoid hemorrhage, if I remember what he said, maybe some microbleeds. And I really like the panels that he's showing here, because in the top left, he shows sort of no real A1, just an A1 blowout with an inflow zone. And then in the top right, you see the distal A1 and then the bifurcation going into A2. So personally, I would flow divert this and let the mass involute. I would put a flow diverter in the distal A2 there. And then I don't know if one will be long enough, probably not. Telescope distal to proximal, and reconstruct this with flow diversion, no coils down in the mass, and let the mass, as Rafi said, it's a big mass, let this mass involute over time.
Elad, this is going to be on the assumption that you don't think her mental state change is due to mass effect, I guess. I mean, he's saying she's semi-comatose, but it's probably sedation, but...
Yeah, so the question is, how was she prior, right? Because it's not ruptured. How was she prior? So if you think she's semi-comatose because of, of the mass, and of course, then you need to address the mass.
She gained her conscious, guys. I mean, she lost conscious. When she arrived at us, she was comatose because of intubation. We waited on her, and we thought she may develop hydrocephalus. She didn't. Again, we repeated the CAT scan, same thing.
So
and
she had
was
good
back. She was awake and she was extubated.
Okay,
She
so if
can't
that's the
find-
case,
The only thing is we needed to do pressors because her heart ejection fraction was low.
so especially with a low ejection fraction and a good neurologic exam, don't get me wrong, this is not first week out of fellowship case, but I would use a telescoping technique and reconstruct the vasculature from the distal A2 down into the carotid, almost ophthalmic region, and get a good anchor.
Can I ask Errol? Errol, what's the role of balloon test occlusion of this vessel? Is there a lower limit of vessels to do BTO on? I mean, I see my good friend Jacques Moret and other French people who seem to balloon test occlude any vessel and say that we remove the guesswork out of it. We can tell before treatment whether this lady needs her A1 or does not. What's your take on?
Yeah, I don't know that there's really, I mean, BTO is helpful when you're more proximal. I think with something like this, if you're going to do any type of provocative testing, I think Amitol works pretty well. You can get into the aneurysm and do selective injections, but I tend to lean more towards a LODS approach. I think, there's two approaches here. Before flow diverters, because as he said, this is not, and I'm glad he prefaced it with that, even in experienced hands, getting telescoping, especially the anatomy, is not clear early on, and getting flow diverters in there and then stacking them all the way down proximally is not that straightforward. But prior to that, you can put really, really large coils in here to just slow the flow down, to understand the anatomy better. And once you start seeing what the ACOM actually looks like, truly where the A1s and A2s are, I think it makes a surgical approach, especially if you trap really early on, a little bit more manageable. But today, I think the best approach for this is flow diversion, because I think you're going to reduce the mass effect, and I think it's your best option. You can't pack this with coils, and I think surgically this is a high morbidity case.
But Errol, do we have balloons? I mean, we have balloons small enough to fit.
Oh, sure.
Why not put a balloon in left A1, inject the MCA, and follow what Raphael suggested to see if there is nice collateral from MCA to ACA and call it a day?
It's easier said than done, and I don't think it's even in large proximal vessels. I don't think it's not 100%. You can get burned with that, and it's also not going to be easy to get the sump effect in here to actually see the anatomy. I mean, look at this. You can even see on the 3D. It's pretty hard to see what's what.
How do you gain access to the A2s with to be able to drop the flow diverter? Sometimes I've seen my endovascular colleagues struggle to try and find the ostium in such a large aneurysm.
Yeah, that's the hardest part. That is going to be the most difficult part is getting the anatomy, because there's such a sump effect here, and it gets into what David was saying earlier, which is exactly right. With your microcatheter, and you can see the takeoff of it there, you have to do selective injections.
One technique, so you can see the takeoff there. One technique is a roller coaster or a loop-de-loop technique. As Errol said, the sump is huge. It's going to pull your wire right into the aneurysm. So go with the flow. Let the wire come in, have a curve on it, let it wrap around the aneurysm. And just like there's a sump in, there's an outflow out. And sometimes if you can just catch the current, and typically this is what we do, and we'll take some finesse and experience, you can ride the outflow out in the outflow zone into that distal A1 and up the A2. Now you have a loop in the aneurysm. So you follow with a microcatheter, get very distal access, and then before bringing up your flow diverter, you have to reduce the loop by gradually pulling back with distal when you have very distal purchase. So kind of different people have described it. Dr. Walkloo, we have Errol's, I've seen you do this. It's a roller coaster or a loop technique.
Yeah, David, whatever is worth, I would do this surgically. I'm just worried about the mass effect. To be ready for the possible, I do intra-op flow measurements and SSEP and MEP, like Raphael says, because you may not need a bypass. But if you do, you could do radial artery. Raphael, to get interhemispheric fissure, I actually learned from a Japanese friend of mine, I mean, obviously, you could take the anterior branch of the STA, hook it to the parietal branch of the STA, and make it a much longer STA that can get there if needed. But that's what I would do.
Sure.
David, back to you.
So just because of the ejection fracture and the fear, even if we did a big surgery that she's going to be under anesthesia for a long time, we were able to cross over to the ACAs, and we start deploying the flow diverter, and every time we do that, it herniated. So we abandoned that. We tried all techniques, maybe better than a lot, but you know, from my hands, it kept herniating and herniating. So finally,
you must be 1 week out of fellowship, David, clearly.
Exactly. So we reverted to open surgery, and we did under SSCP's monitors. But then we waited a couple of days. The cardiologist finally got her ejection fraction to about 40, 50. We have a cardiac anesthesiologist, really good, was available to help us out during the surgery. We did what Raphael mentioned. We put the temporary clip on the SSCP's all dropped motors. So what do you guys do after that? I had the STA ready to go, but it was short. I could put it there. I only can get it to the proximal A1. I could not get it distally to the ACAs. I mean, the distal part of the A1. I'm sorry, where did that take off? The aneurysm. What do we do, Jack, then? I did not prepare for radial.
Ah, okay. Well, so you could reach the distal A1, you said?
The proximal A1. I could not get to
so you could not reach beyond the aneurysm?
Correct.
Well, the trick I just mentioned is to, you know, to add to the STA the other branch, you know?
Yeah.
End to end. That's a neat trick. You know, it's a trick they use for moya of the ACA territory for bypassing interhemispheric.
So we ended up, just to save time and not bore everybody with the story. So we tried to clip, we put multiple clips on it by doing temporary occlusion of the ICA terminus to deflate the aneurysm. And every time we deflate the aneurysm, put the clips, they sit just fine. As soon as we take the temporal clip, they spit it out. So what we ended up is resecting the whole aneurysm completely out. And then what we did is we reconstructed, we dissected distal ACAs, and we recreated the ACOM complex. We connected the ipsilateral, I mean, the whole thing, we moved the ACA and connected distal to proximal. So
you mean end-to-end anastomosis of the A1?
Yeah.
The gap was you could break the gap?
Yeah, I undermined it because when we did that, they were really not that far from each other. And we were able to do that. We did intraoperative, I'm sorry, just like it went well. We did that also perfusion, CT perfusion to see if there's any penumbra risk. You know, we need to pump the blood pressure. Everything went. She went home the 4th day, and she's heavily caring for her son. I'm sorry, but that's what we did.
That's great. Well, tough case. Comments from the panelists or speakers?
That was a great case, David.
Thanks, sir.
Amazing
All
case.
right. Yeah. And she named her son David, I guess, huh? Or that girl?
I persuaded to make it to a more handsome name, Jack.
Okay. Great. Errol, let's have your case.
All right. Let's see. All right. Let me share my screen here. Can you guys see my screen yet?
Not yet.
Okay, let me see. Let's see, sorry here. Sorry, let me.
Is your presentation already open on your desktop?
Yeah. It's not letting me select Windows screen. You still don't see it?
No?
No, we cannot see it.
You're clicking on that green box, share screen?
Yeah. No, I mean, let me see. It's preventing.
Iggy, any suggestions for him?
No, I mean, if he says it's going to the green screen,
Yeah, and I don't know why. I literally just did this this afternoon. God, I apologize here. It says my browser's preventing access to share my screen.
Are you at home or at the hospital? Sometimes maybe the.
Yeah, no, it's my internet's fine. It's not. It's not that. It's just. I'm on my laptop, so. Geez, let me. Sorry. Let me try one more time. I don't know why.
David, you mentioned you had herniation. Great case, first of all, and great surgical salvage. One thing we do to prevent those kind of catheter herniations into the sump is when you microwire way out into the ACA, like A3 with the microcatheter, take your navigating wire out, whatever you use, Synchro, Chikai, whatever, and we put in a hydrophobic wire, like an Asahi hydrophobic, so it's sticky. And once that wire is out there, you sort of won't herniate and you can reduce the loop, and now you have distal access that's really stable. But that is a huge problem, catheter herniation. And I think when they've developed these hydrophobic wires, that sort of helped us kind of create like a Velcro stickiness out there to prevent herniation. But again, great surgical save in that patient.
Believe me, I would love to kind of have you there or have an extra hand to help with it. But that's what I would try, man.
Let me see. Jack,
Yeah.
I'm sorry why this is. I don't know why this is blocking me.
That's okay. I'm not sure.
One of the case. Let me just see if I can get into the firewall here. But one of the cases that I wanted to show was kind of this combination. I think Raphael, that Gartner scale was actually fascinating. That is something that I think really describes really well where we are with open and endovascular. And we're basically. If you look at where we are, I think this balance, endovascular is not going away. And I think fortunately now most of everybody being trained is now trained in open and endovascular together. And I don't, the recurrence is clearly an issue for endovascular. There's no question about it. I think we can do it safely now. The technology is getting better, but the recurrences, and I actually had a couple of cases that I was going to show where endovascular every day of the week, I think most people would say, let's start off with this, but there's recurrences. And I think surgery becomes our mainstay, especially in younger patients. So, I think the discussion is, and I'm, interested in all the panelists, as well as the speakers, but, where do we find that balance? I think it's a mistake to say coil first, clip first. Every patient, every case, you have to individualize based on age, based on medical condition, and also electively a patient's preference. So without question, endovascular is getting better. And those recurrences, as you see, are going to get less and less and less. But I think in the interim, and certainly I think in most of our lifetimes, open surgery is still going to be an option. And it really comes down to choosing the right modality. I'm going to try one last thing here.
While you're trying, I'll comment on something while you're trying. So to answer your question, I remember the paper by Chris Ogilvie a few years ago, that scoring scale, what is it, ARSS, 10 or 11 points to predict which aneurysms would recanalize after endovascular treatment. Interestingly, I don't think it had caught on very much, but I thought that was a great idea. If we could predict a priori, I remember his graph with the bar graph on the 11-point scale, getting more and more recanalization the higher the score was. I mean, that would be a nice way to say a priori, okay, let's score this aneurysm on the ARSS score, and if it's too high, don't even attempt endovascular. do microsurgery. That you know, that would be my take on. I mean, now of course that score changes over time as technology advances, but you know, instead of saying let's see what I can do and render an aneurysm that would have been quite easy surgically into an endovascular monster, you know, with partial recanalization. And, you know, that's what's happening, not in the hands of experts like you guys, but, you know, in small community hospitals where perhaps some endovascular folks are not as well trained as you guys, and, you know, and don't treat aneurysms truly completely and cure them endovascularly. But that's my take on this.
John,
Yeah.
one of the reasons I'm sure you have me in the spirit of our friendship is because you know I'm going to tack the sailboat in the exact opposite way, which is what you'd want me to do.
Go ahead. No, go ahead.
And Errol was a co-author on this paper. I think it was 1,000 aneurysms, recurrence rates, much ado about nothing. That was the paper title. I wanted to say something more crass, but Nelson Oisika wouldn't let me. So he changed the title to much ado about nothing. Mine was who gives a, and you can fill in the blank. So I think for unruptured aneurysms, we showed in the literature that a recurrence of the neck has a 0.0 rupture rate and a 0 point something or less than 1% complication or retreatment risk. Now these are experienced centers, to your point. So when you're coiling unruptured aneurysms, a little neck is okay. And I think when we clip aneurysms and leave a dog ear, nobody says anything, and nobody would ever think of going back in on a little recurrence of a clipped aneurysm. So it's a little bit of a different, we hold them to different standards. Ruptured aneurysms are a different beast. And I think if you are going to do endovascular treatment for a ruptured aneurysm, you really need to make sure that if you don't, as we talked about in the talk, don't block yourself out and don't eliminate the chance for fixing it, like in a web device or another device where you can't get back in and do something to fix the recurrence. Because in a ruptured, that is a serious problem, and it makes surgery, as you mentioned, Jacques, a monster, a coil monster.
Yeah, but I mean, yeah, I respect your opinion of that paper, but I mean, remember I think it was retreatment, not even residual. It's the ones of the residual that felt needed to be retreated, and you got some, I don't remember the numbers now, but some big, oh, you made it.
There we go. I just had to switch browser. I'd finally got it. Thanks for saving me with a small chat there, guys. I appreciate it.
Well, Errol, it sounds like a typical technical problem like you have in your Angio suite every day. Thank you for showing us.
We gave him enough time to write the PowerPoint on the fly.
Yeah, the difference here, Jacques, is I'm going to show my pictures, my intra-op and my post-op. So.
All right, let's do it.
So let's go. So I actually just changed around the cases because I really, as I said, I want to tie this together. Especially for a lot of the younger viewers and fellows and people that are just starting off out there. So here's a case. It's a 75-year-old woman who presented to our emergency room, actually delayed during COVID. She had a Hunhess grade 2. Her actually rupture was probably about 10 days prior. And she presented with a seizure to the emergency room. And she was on Plavix for cardiac stents and allergic to aspirin. So I'm going to try to get the best view here, but this is an MCA. There's a wide neck here. You can see here's the MCA here. Here's a better view. You can see the neck here. So what would, real quick, and I'll fly through this.
Sorry, for the young people of the audience, go back to that second picture. Just show them where the second branch is coming out of the base. Is that right? The branch that's coming out? Yeah.
Right here. Yeah.
Okay. Sorry, go ahead, Aaron.
Well, actually, so I'm sorry. If you're referring to this is the neck.
Right? Isn't there?
There's a branch here. This is a branch in the back. Here's the neck, and I flip back because it's here's branch here, and there's a neck. It's broad based, and I kind of didn't. This kind of gives it away a little bit, but
okay.
It is a very broad base.
Okay. Elad.
How old is she, Errol?
75.
75 years old, on Plavix for cardiac stents. And presented with.
I'm coiling this every day. This is unruptured?
Hun has 2.
Anesthetic rupture. I'm
Away
calling
10 days ago.
10 days ago, 100% I'm not operating on this in vasospasm period, 10-day rupture. I'm calling this every day of the week, 75 on Plavix. She does not go to the operating room.
Do you tell us about technical things? Do you expect balloon remodeling? Do you do a web? What do you do with this?
What I might do is park a catheter out of that one MCA branch that looks like it might be coming out of the neck. It is broad neck, but I may kind of put a catheter there in case I need to protect it. But I'm going to try to coil out the dome. 99% of aneurysms from autopsy series published rupture at the dome. 1% rupture at the neck. So if I leave a little bit of neck in a 75-year-old, I'm okay with that. But if, you know, she's 75, coil this, live to fight another day. You can come back and deal with it if she gets out of the ICU.
That's a big, I think a really, really important point that, you know, these kind of point counterpoints. We talk about recurrences, and I open this up to anybody. I've never, ever in my entire career have I seen somebody have a recurrence that has not been followed that's ruptured at the neck. Even a broad-based coil compaction, you know, the bleeding is either along the wall or at the dome.
Rafael, you agree with Elad? A good endovascular case in Hopkins? You're muted. You're muted, Rafael. Rafael, your microphone is muted.
Oh, yeah, sorry. No, I completely agree with Elad. I would pay money to Cameron and Justin Kaplan to coil this.
You need to pay them to do it? They wouldn't jump on it?
No.
Okay.
So Elad, why not web?
It doesn't look like a web to me. You know, remember I said it's got to look like a round ball or a dome, and you're going to come in the neck sort of at 6 o'clock, but the dome is more at 4 o'clock, so you're going to have to torque it. I'm not saying no, but I just think it's going to add a challenge that you may not want in a rupture right now. So I think I can get a pretty good coil pack, at least in my hands with this. I wouldn't say no, but I don't like this for a web because it just doesn't look right. You know, it's like a boot. This looks like a boot, and not versus a barrel or a ball.
Nilesh, opinion on this case?
I think given the medical issues of the age and the Plavix, we would typically at least take her to the angio suite and see if the first coil can sit without herniating into the parent vessel. And if for some reason the coiling didn't go smoothly, then halt the Plavix. Like the conversation we were having earlier, maybe consider Amicar if there's going to be a little bit of a delay getting her to the operating room, given the window of vasospasm. And then the clip would be straightforward in terms of the surgical technique. It's really just the medical comorbidities that would make the craniotomy, the anesthesia, more difficult.
All right, Errol, back to you.
Yeah, so you know, those were actually all thoughts, and we, you know, tended to go with Elad's philosophy. I mean, this just didn't look. I mean, it's not even just a look; it's a wide neck. So I think with the web, my guess is we're going to get into trouble with web down the road. I think the recurrences with web, they're no better, and in some cases, depending on the data, you know, worse than standard stent coil. Problem with that is with a stent coil, you can come back and easily pop a couple more coils in. Web's going to, you know, we're very careful about that, but I think because of the size of the neck was an issue. And this is on the contralateral side. She has this cavernous aneurysm, and actually it's much more dysplastic. So I'll just kind of point that out rather than getting into a discussion about what to do. We'll go into the treatment. So we coiled this. And you can see we got a nice result. There's actually the neck is right here, and there's the coil mass. And back here, you can kind of see it on this oblique view. So we got a nice result. She did very well. And then every patient, we still do angiograms at 6 months. I'm not sure actually out there if people want to put in a poll in the chat room there, how many people do 6-month follow-up angiograms after coiling, how many people are going to CTAs, MRAs now. I think there's definitely been a shift, but we still do 6-month follow-up angiogram. and this was actually a little less than 6 months, and you can see this recurrence. So this is and here you can really appreciate the neck much better.
Let me say here, I mean, this is view. I mean, this is perfect view. This is down a lot. This is like a perfect for web, that view. Correct? Yeah. This looks perfect.
No, this is a different view. And yeah, you could come in and kind of web this now with the coil mass on top with the barrel shape straight up. Yeah.
I've done this with big aneurysms where we coil on the top and then cork it with a web at the bottom. With a
web with a little wig of coils.
Yeah.
So Elad, you may know this better. I think you guys have a pretty big series, and David and anybody else. I mean, I think there is some controversy over the, how the web's behaving with coils in these recurrences.
Yeah, I mean, like you pointed it out. So depending on how dense your pack is, that may cause your web to torque. You have a small branch and a big branch. You could web this. You've already coiled it. She's 75. I think, I first of all, if we talk coil, I love gel-coated coils. The heat trial showed that the recurrence rate is less. I really believe Bernard Bendock, obviously was one of our co-fellows and a friend of all of ours. He was a PI on that trial. It was great data. So at this point, I don't know what coils you use, but I'd swap over to gel-coated coils and recoil this thing. You got a good result to the beginning, and you can recoil it or even stent coil it.
She still has ongoing comorbidity? She has a coronary stent on.
No, she's medically stable. I mean, she's got, now it's not acute. This is like 5 months later. This is right when we started opening up with COVID. So now she has, she's stable. I mean, she has a cardiac stent, was on Plavix, but there's no reason.
Right. But I mean, at that long, they can take you off. They allow you. I mean, in our hospital, they allow me to take off Plavix for 7-8 days.
Right.
Oh yeah, same here.
Yeah. Rafael, I want to clip this. Are you with me? You're muted.
Yeah. Well, I think you could. It should be from an anatomical perspective, it should be pretty straightforward.
The ratio is a lot more than 2 to 1, plenty of space.
Yeah, and the coils have moved up, so there's room for the clip. I think, I think it would be reasonable, but I think another round of endovascular would be okay as well. I mean, she's 75 and has cardiac disease, and but I think it would be okay to clip if everyone wants to proceed that way. Yeah.
No, I want to clip particularly because nobody wants to do it. That's why.
So can I say something? This was a grant I did, and we finished the study and everything. If you look at this aneurysm, which we showed it by doing a 3D CT and measurement, this coil compaction is not just the aneurysm recurrence. It's not just due to coil compaction. The sac itself elongated, and that's what we show.
Exactly.
So if you're just going to coil it back, it's going to come back again, and we've seen these cases. So either use a stent to really divert that, or I firmly believe in flow divert. I mean, a web or clipping. So for this, for me, it's either a web or a clip. Otherwise, if you coil it, it's going to come back, and we all seen those comes back again and again and again.
David, that is an excellent point, and what David just mentioned is exactly right. This is, yes, there's compaction here, but this is an elongation. This is a different looking aneurysm than what it was before. And these are the ones that become worrisome with the recoiling. These are the ones that you see come back 2 and 3 times. And this is what bothers me as well. You're starting to see into the dome. And so our options at this point were exactly that. Was flow divert, was we're going to do stent coil, really pack it in. Now that we had the luxury, she was not a subarachnoid hemorrhage. Or a web in here. But I think this is probably, we should document this. Jacques, this is probably the first time you and I agree on a case like this, that we're on the same page.
Thank God you're growing up. Fantastic.
So if you see the ratio here, if you see you have purchase, you know, if you have coils up to here, these become really treacherous to clip. This is where you start to pinch off the branches. So I think based on what David said, based on the amount of neck we had here, we went to the operating room. And this was, you know, again, I think the point of this is that this isn't someone you can randomize to clip first, coil first. The best thing for her when she came in was an endovascular approach. She did great. She went home, she's fine. She's now back with essentially an elective aneurysm. Now, it's an elective aneurysm plus because we know it was a subarachnoid hemorrhage and we know that we have to be more aggressive in treating this. And this was actually a fairly, and I'm sorry, these are really fuzzy. These are the intra-op pictures. I mean, this was a fairly straightforward case. I mean, there was a lot of great purchase. It was one clip. In the intra-op, you know, we got a really good result and she did great. And she went home in a couple days. So, you know, I think the lesson here is really using all the tools in your belt and, you know, doing what's best for the patient at that time. That's actually a better where you can see the branches. And, you know, we got great clip apposition. I don't know if we have time, but there's another.
We don't, unfortunately. I don't want to keep, I'd love to keep listening, but, you know, I don't want to keep everybody up. But
Yep.
I just reading the Q&A, I'm delighted Pedro Lilik is actually listening to you guys. And he sent, Pedro, how are you? He sent a comment, why stent and coils? That was his suggestion. I guess before you said clip 5 minutes ago.
Why stent and coil or why not stent?
No, why, the Y-shaped stent and coils.
Yeah, that's I mean, that's what we do, Jack. I mean, I'm sorry, I'm taking that answer from you, Errol, but you cannot just go coilless. It will come and compact. So either you do a Y because it has some diversion flow, and as Errol said, you compact the hell out of the aneurysm. Short of that, it will come back unless either you clip it or.
And I think there's a pretty good chance even with that you'll end up coming back. You know, probably not so much as this, but those were the decisions that we brought in. Was that this was, you know, this is a straightforward MCA with a great amount of purchase there for the clips. And, you know, it was almost like doing an elective case.
It's perfect case.
Errol, I love this case for this because for all the fellows and residents, you have over 100 people listening. It shows why these are complementary technologies. If you're going to be a cerebrovascular surgeon, endovascular is a tool, right? It's a tool like open surgery, and by having a well-developed toolbox, right, for the next generation of these vascular, cerebrovascular surgeons, it allows you to develop the art. And in your center, this was a great choice. You know, I personally probably would have done what Pedro is suggesting and David and stent out the dominant branch with a L shape and coil, but that's now art. That's art of decision making, and there may not be one right answer. This was a great case because there are several excellent options. Great case.
Well, gentlemen, any last comments to each other, anything before I let you all go? No, I'd like to thank you. This was a terrific session, as I knew it would be. I have a great, a wonderful taste in choosing my wonderful speakers, and I proved it again, shows some of the best people to talk about this. Thank you all. Thank you to the audience. See you next week. Bye, everybody. Thank you.